95057 or go online to WGBY.org.
This is WGBY Springfield.
We're taking your questions on end-of-life issues, palliative and hospice care, next on Doctors on Call.
Doctors on Call is brought to you by the members of WGBY and by
Mercy Medical Center is proud to sponsor this program. Mercy is committed to providing you with high-quality care through the use of advanced technology. Mercy Medical Center, improving the experience of healthcare. Learn more at mercycares.com.
Footed Healthcare Store, serving the Pioneer Valley since 1953. Footed's caring staff will help you find the products you need to live your life well. Footed at Memorial Avenue, West Springfield, or online at footed.com.
Hello, welcome to Doctors on Call. I'm Jim Madigan. Every week we are here talking about your health. You can take part in this program. It's an interactive form after all. All you have to do is get in touch with us with your questions. You can call us at 1-800-639-9120, toll free anywhere you are, or you can email us, which is kind of a nice option, provides you a little extra privacy. And the address there is doctors@wgby.org. Our topic this week focuses on end-of-life care and issues. Kind of a difficult, sensitive topic. Here to respond to your questions or comments are Dr. Jeffrey Zesiger. He's a palliative care specialist. He's medical director for the VNA Hospice of Cooley Dickinson. And also with us, Maureen Groden. She's a registered nurse with a special certification in hospice and palliative care. She is the manager of hospice and palliative care for VNA Hospice of Cooley Dickinson. Now, as you call or email, please do remember that our guests can only give you rather general answers to your questions in most cases. Please don't think of this as the kind of specific advice or individual instruction you'd be receiving from a medical professional if you actually saw them in the hospital or the office. If you have any medical problems or concerns, of course, we do urge you to see a physician. At the end of this program, we're going to tell you where you can find a little bit more about tonight's specific topic, so you may want to be ready to take that information down. We're going to direct you to our WGBY website, where there's some information and some links to information about hospice care. With that said, again, phone lines open, emails available, and I know this is for a lot of folks a difficult topic, a sensitive topic, maybe something you haven't thought about, so you may tend to sit back and formulate your questions or your thoughts or something you want to share with us. This half hour goes by really fast, and so often we feel so bad when at the end of the program there are 3 or 4 calls waiting that we just don't have time for, or a couple of emails come in just as the show's ending, and a lot of times they're great questions. So if you've got a thought you want to share, a question you want to ask, now's the time. Get on the line, get on the email with that. To our guests, thank you both for coming in. It's good to have you back.
You're welcome.
Let's talk a little bit about, I think there is some confusion. Big word, palliative, and it's got one of those Latin roots, and you look it up, and the original meaning is to cover something, believe it or not, but to deal with something, to treat something. What do we mean when we say palliative care?
Well, I like your background about the Latin meaning. The covering for me is like a cloak or a hug. So I feel it's a team-based approach. So we come in and just help people with being comfortable and discuss very carefully what are their goals. Because in medicine, it's very easy to enter a hospital or be in a doctor's office and not feel like you can ask the questions or not say what you want. And we push very hard for all of the team to just talk to people about, are you comfortable? Find out how we can help you be more comfortable, and what are the things that are really important to you in life right now. Because at each time in your life, you have different things that are important, and when you're nearing the end of your life, you have very different things you need.
It is a unique area of care, isn't it, Maureen Groden?
It is, and the folks that have or need palliative care are often really sick, and they're oftentimes getting a lot of treatment. They're often in and out of the hospital. So palliative care offers a team approach, and it focuses on comfort, it focuses on patients and their families, because it's a tough road to navigate when you're that sick and you have a lot of complications along the way. So palliative really helps people, mostly in the last year or two of their life, to manage their illness.
I've got a lot of questions. Before we go any further, though, I do want to mention something that I just learned about. VNA Hospice of Cooley Dickinson, based in Northampton, recently named, and correct me if I get any of this wrong, a Homecare Elite 2010 agency, which really cool in your industry. It means basically that in a survey of, and I'm told there are like 10,000 of these home care, palliative care agencies across the country, means you've been ranked for the quality of your care you provide in the top 25%. And that's in a difficult field, I would think, where sometimes even the best of work may not feel right to somebody. Yeah, and I know. I mean, when somebody's in that stage of life, sometimes it is hard to work with, I'm sure. But you've been recognized, and that's a great thing. We congratulate you.
Thanks for bringing it up. It's a great pat on the back, and the staff really work very hard. So it's taken years to get people to a place where they can just work in such a good team.
Yeah. I think the entire agency deserves credit. We've worked very hard to achieve outcomes that are in the top in the country, so we're very proud of that.
The thing that occurs to me is so often in medical care, the regular going to the doctor for the earache, the backache, whatever the problem might be, whatever specialty you're seeing, it tends to be until we get maybe later and we need help or a ride or little kids or whatever, but it's one-on-one. It's the doctor and the patient, the nurse and the patient, nurse practitioner. I would think a lot of times you're dealing with family, patient and caregivers and support group. And you're not treating one person in a lot of cases.
Indeed, and whether you're in the hospital or at home, it's not just that one person's going through such a difficult time, it's that the whole family's going through a difficult time, and they really need help to just support them as much as the patient. So a lot of times we notice that the family's worried more about the patient's worried more about the family, and we just have to get in the same room to say, come on, we're all in this together. How can we help you?
And I would think, again, in your case, your workers are dealing with all sorts of situations.
Right, and we walk right into people's lives. So obviously we're walking into people dealing with not only physical problems, but dealing with financial problems, dealing with emotional reaction to having an illness. So it really is very holistic, and the fact that it's home care also, we really deal with the family and all that goes with their illness, really.
Go ahead, doctor, I'm sorry.
So I'd add in that in our roles, usually you're a doctor or a nurse, but I think in this kind of work, we really all take on a little bit of each other's roles. Because you might be the person that brings up this new idea of, gee, you might be in the last year of your life. You never know who's going to bring something like that up. And if we can all be a little bit social worker, a little bit of a nurse, a little bit of a doctor, health aide, whether we're getting somebody a glass of water or we're talking to them about their medical exam, it's just something that really shows that we care. And then they feel more relaxed, they're more willing to talk to you about the things that matter to them, and then you can find out what they really need.
I know there was an interesting profile done a while ago when you were really moving into this field a couple of years back, the Daily Hampshire Gazette, and I looked back at that again today to prepare for the program. You talked a lot about the fear and anxiety that surrounds, and I guess that's any time we go to the doctor or we're in the hospital. It's an anxious place. I mean, everybody's waiting to get better or waiting to hear what the results would tell. There's even a different kind of fear and anxiety, I would think, with someone who's gotten those results and it's telling them really what the rest of their life is.
Yeah, anybody that's been ill just knows that all of a sudden one day you're fine, the next day, wow, the rules have changed, your life's changed, and that's just for a simple illness. Even if a friend of mine just came in with appendicitis. All of a sudden his life was totally different. He was worried, would he get through the surgery, had a complication. He's fine now. But to imagine that somebody says to you, you're not going to live much longer. You might have 6 months. We see it from our point of view, and we can help people, but to personally feel that, each person feels it themselves. And you're right, anxiety becomes the big elephant in the room. People talk about what's your blood pressure, what's your heart rate, how bad's your pain, but people really don't talk about their anxiety, and everybody has it.
Yeah, I think that it's really difficult to deal with being told that you have a life-threatening illness, and it affects everyone. And I think that oftentimes people are in different places in their willingness to talk about it. So some people have a hard time talking to their doctor about it. Sometimes family members have a hard time talking to the patients about it. So it makes it really, like Dr. Zesiger said, an elephant in the room. And we find that if we're accepting and able to take people's cues, people will say things like, I'm tired of all of this, or I'm sick of being sick. Mm-hmm. And a lot of times people would say things like, oh, but you're getting better, or things like that, as opposed to just allowing people the opportunity to then talk about what do they want now. Mm-hmm. And I think that that's a key thing. Like you said, sometimes it's the occupational therapist, sometimes it's the physical therapist. So all of us play that role in just helping people to navigate that path.
And some of the things we don't really know when we first meet somebody. Are they going to get better? How much might they get better? Would they be getting ill very quickly, or would it take a while? And it's a moving target. So you meet with people, you share what you know, you find out what they know and what they want, and then you meet with them again the next day, the next week, whatever, and you find things may have changed. And then you have to readjust what their goals are.
I know so often, now obviously there are any number of illnesses, but I would imagine cancer, just by the very nature of it and how sometimes predictable it can be in terms of we know at a certain stage, more than likely a person has X number of weeks, months left. A lot of the people you see are cancer patients. And pain is often a big factor there. And I know pain management, dealing with pain and the anxiety that not only the pain brings, but how do you deal with it brings for people and for families is a lot of what happens in hospice care. Is that correct?
It's probably the most important thing. Anxiety is, the unspoken one. Pain is the one people are willing to talk about and really, really want control of their pain. And we really have to do a good job with that. But once you do, people are comfortable, they start to relax, and they trust. And they know that they won't be so out of control. I think people are really worried about being out of control, and studies show that people are less afraid of dying. Many studies say 50, 60% people will say, yeah, I'm afraid of dying. But 80, 90% of people say, I'm afraid of being in pain, short of breath, or being alone. And those things really get people right in their heart.
And I think of your individual caseworkers, your individual people who are in the homes with people, and how hard, obviously very hard for the person who's sick and their family, the person who's in the process of leaving us, but very hard for the workers too, I would think. There's got to be a stress level there.
It is really hard. It's very stressful, but it's also very rewarding to be able to help people at a time like this. It's really a privilege to walk into people's lives. The skill set is high, and like you said, managing pain, helping families with chores. We have wonderful volunteers that help with chores, sit with people. We have home health aides that help with bathing. So it is very difficult, but the folks that choose to do it do a wonderful job at it. And people's stories are amazing, and we are able to go in and hear about just amazing stories. This past weekend, we took care of a man who was a veteran, and his son told me his story about when he was a World War II veteran and a prisoner of war. And so it's amazing. It might surprise people to know that 1,800 veterans die each day in this country. One of 4 people that die in this country are veterans. And so, we kind of walk in people's lives and hear their stories, and it's a really amazing story. But the staff, it definitely takes its toll. We all support one another in this journey, and so that helps a lot. I think that it's a team approach, and I think that any one of us could never do it alone.
We do have some calls online. We're going to get right to them, but I just got kind of an interesting insight into what you folks do, because the folks in the control room told me that a couple of people call up and basically say, you know, I can't go on, I can't talk about this. And that's, there's a pain, and there's a psychological as much as physical. Let's go to our caller from Springfield who been kind enough to wait. Go ahead, Springfield. What's your question or your comment, please?
My question is, yesterday I had a kidney surgery where they blasted out 2 kidney stones the size of golf balls. And today I got a fever of 100.9, and I threw up all my regular medication.
Dear, that's
wow.
Difficult situation.
You've had a hard couple days. I hope you've called your doctor about that because they'd want to know if you're having nausea or vomiting. The good thing I'm hearing about your question, though, is that this is something that will lead to your kidneys working better, and without those stones, you'll be feeling more comfortable. So luckily, this isn't a life-threatening illness.
Thank you very much, caller. You know, I'm glad we were able to have that caller get through to you, because there's an example, not a person in hospice care, and we sure hope she gets completely better, but
we want her
you were able to hopefully give her a level of comfort there, ease her concerns, which would be very real. With
Absolutely,
symptoms.
because you go through a procedure like that, it's big no matter what. And just to have somebody vocalize that they're with you and they support you, that helps. Or somebody to hold your hand. I think there's nothing like touch. So I hope somebody's there with you tonight to give you a squeeze and say, okay, you're going to get through this. But make sure you do call your doctor. That's very important.
Yeah, good luck with that caller. We've got a couple of emails, and I'll go to a phone call because this person's been waiting a couple of minutes. Granby, go ahead. You're on the air. What's your question or your comment, please?
Are you giving care to the patients who are currently undergoing chemo or radiation?
Great question. Yes, indeed we are. And that brings up the answer of what's the difference between palliative care and hospice. Palliative care, as Maureen said, could be for somebody who's in the last few years of their life, whereas hospice, usually by the regulations for Medicare, are the last 6 months or so of life. So if somebody's getting chemotherapy, they might have more nausea, they might have more pain, they might have more side effects of medicines, and palliative care would get in there and help them with that. It wouldn't say you couldn't do any treatments, it would say we're here to help you do the ones that you want to do. And you just let us know if your goals change, and then we can come in more or less to help you with that.
Yeah. I think the similarities between hospice and palliative care are that they both focus on symptom management, managing pain, nausea, so forth, and they also have a family and patient focus. The major differences are that with palliative care, there isn't as short of a prognosis requirement. In other words, people can be not necessarily in the last 6 months of their life. The other difference is in hospice, it's more of a comfort care plan of care, where palliative is people getting active treatment, going back and forth to the hospital. For the most part, folks on hospice stay either at home or in the nursing home, wherever their home is, and are usually getting a different type of care. It's not a lot of IVs, transfusions, chemotherapy, that sort of thing. They're really on a supportive track.
Believe it or not, we got 8 minutes left. We've got quite a few emails, so let me start working through them. Here's one that, well, an important question, but kind of breaks your heart. Would a young child be a candidate for this type of care?
Absolutely. Absolutely. More than anything, we really deal mainly with adult-related illness. The hospice at Bay State works with children, and it's even a super specialty among our specialties. And people, if they're a child going through treatments, whether it's a cancer or something else, they and the family need extra help. And then if they're on hospice, all the more so. So kids, absolutely. We'd all like to just scoop them up and hug them and tell them it'll be all right. But when you know they can't be fixed, they need extra care. I
have an email from a health professional, and you know what, Maureen Groden, I'm going to turn this one to you because it comes from an RN. Okay. She says, as a nurse and a family member, I have found it difficult to work with others and pain meds. Many people are afraid of addiction to the pain med. The thing that concerned me more were caregivers afraid to give pain med because it might be too much and end a patient's life. What's a good way to approach these concerns? I was always worried people were under-medicated, not only because of their fear, but because of caregivers' fear. And she actually, we'll tell you the name after off air, but she says, "Hi, Dr. Z." So I think she wants to hear from both of you. But, that's a concern for your people, I guess.
It's a common problem. There's a lot of myths around giving pain medicine, that it's going to cause someone to die, that the side effects are going to cause people to be more miserable. Really, a lot of diseases that we see, you oftentimes need to have pretty strong pain medication. And it's a common problem that we see, that a lot of nurses have difficulty with giving pain medicine. And so we try to educate people all the time about how important it is to provide the medication, that oftentimes people are on the maximum amounts of their medications, whether they have heart disease, lung disease. If they have a lung disease, they're on the maximum amount of medication to facilitate their breathing, that oftentimes it is the stronger opioids that actually provide more comfort type medication. But it's a real problem when we educate people all the time about it.
And we can easily say that if you're on hospice and you're in the last 6 months of life, it's impossible to become addicted to your meds. And my definition of addiction is you're willing to rob a bank, lie, cheat, and steal to get more of the medicine. Instead, people on hospice, if you have pain and you have this much pain, you better have this much pain medicine to balance it out. If it's not enough, you're going to still feel lots of pain. If it's too much, you might feel groggy. So we keep adjusting to make it match the amount of pain you have. And if that pain changes day to day, you have to change your medicine. So it's not an addictive problem. Somebody in palliative care, you might be with palliative care for a few years. Could you have addiction there? It's still very difficult because you have pain and you're getting that medicine for the pain. So we don't run into that problem very much at all.
Very good. An email from a gentleman who wonders, are there guidelines for when doctors should refer a patient to hospice care? Are there problems with referrals coming too late, such that hospice staff doesn't have time to properly prepare the patient and family for the inevitable? That's an interesting question.
I'd like to say that if there's one message I'd like to get across today, it would be that many, many, many more people are eligible for palliative care and hospice that actually are able to access this service. That nationally, the length of time that most people are in a hospice program is about 21 days. So they're eligible for the service for up to 6 months and sometimes longer. So I think what happens is people aren't having the conversations, people aren't familiar with what the guidelines are. What is a sign that, for example, someone with Alzheimer's disease is in the last 6 months of their life? Or what are the signs that someone who has emphysema? And so our agency, VNA Hospice of Cooley Dickinson, is doing a lot to educate area physicians and nursing homes and so forth on what those signs are.
Okay, now we've got a full load of calls and a couple emails. Let's see what we can do in about 4 minutes left, a little less than that. Bolton, Connecticut, what's your question or your comment? If you can be brief. Go ahead, Bolton.
Yes, I have a comment. A few years ago, my mom got sick, and I had two sisters. One passed away since, but they were afraid to come around her, and my husband was afraid. My kids were too young, and if it wasn't for hospice, I don't know what I would do, because I was never around a dying person, and they were there for me. And that was the last 24 hours of her life, but I just couldn't handle it. And they were there for me, so I really thank you.
We thank you for calling. That's a beautiful testimony, and that's what it is. Nobody goes to school to learn what to do about end of life. If we go back to 1900 and your great-grandparents or mine, well, a lot of people died at home and people had experience. In our high-tech society, people have less experience. People don't know what to do and they can get overwhelmed. So they may just avoid being with somebody, but that's the beauty of a hospice. The staff are not worried about it. They're very comfortable. They're there to help.
Real quickly, a person asking about, are there after-death services, bereavement services available, whether it's through hospice or palliative care agencies, hospice agencies? What can you tell someone briefly about that?
Absolutely. It's a critical part of the program that folks that have hospice services, we keep in touch with them for up to a year, 13 months actually, after the death of a loved one. So it's a huge change in people's lives. So we have a series of phone calls, newsletters, bereavement groups. So that's a critical part of the program. We have a website too. It's www.vnahospice.org, and there's information about bereavement programs. Our bereavement coordinator also can provide information about resources throughout the Valley, but it's a huge piece of the program.
Very good. Let's go. We have one call. We have 1 minute. Let's see if we can do this. Lennox, go ahead if you can be brief. Lennox, you're on.
This is Walter. And my wife has cancer. She just came up with it, and we are grown children of this lady, and we're at a quandary. What type of choice do we have between radiation, chemo, or surgery? And we're all just guessing what way to go with. I'd appreciate.
You got 30 seconds to comment. What would you direct a family with this concern?
I would definitely say talk to your oncologist, the cancer specialist, because they have the most experience to say what made the difference, what might make the difference, and how hard it is to go this treatment, that treatment, or the other. And if you kind of get an idea of what's going to be the benefit and what it might cost you to try to do it, then you'll have a better idea to make an answer.
And that is all the time we have. Let's quickly tell you more information. Go to WGBY.org, click on local programs, some web information and web links there. Next week on Doctors on Call, the focus, vascular surgery. Anything you want to ask us, tell us, suggest future topic, call 413-781-2801, extension 268, any time of the day or night, any day of the week. We'll get your message and we'll get back to you or try and help you out with the program you're looking for. So thanks to our guests. We'll see you next week on Doctors on Call.
Doctors on Call is brought to you by the members of WGBY and by
Footed Healthcare Store, serving the Pioneer Valley since 1953. Footed's caring staff will help you find the products you need to live your life well.
We're the place where the choice is yours. Footed Healthcare Store.
Who really built Stonehenge and why?